I think an important concept that hasn't been mentioned in this meeting yet is that of the burden of proof. You know, do you give a vaccine to an infant when you do not know for sure that the benefits will outweigh the harms? And of course the answer is no, and I think this is why our peer nations have not chosen to do this for non-high-risk infants at this age. And we've talked about the limitations in the randomized control trials and the data that we have to really rule out serious safety issues on a magnitude that, you know, where, you know, at a magnitude that where we would say that the benefits for sure outweigh the harm. So because this is such a low risk situation, you really need to have a very large randomized control trial with long follow-up. It would be tens of thousands. And we just don't have that information. And so then the question arises, should we give the hepatitis B vaccine at all in childhood? And so I think a lot of people have brought up a very fair point. What is the difference between giving the vaccine routinely at birth versus at 2 months? And I agree that we really don't have good data to distinguish those two. It is a different situation in terms of informed consent, right when a mother has given birth, that there's a lot going on. And I think you brought that up before, Dr. Malone. And so, again, I think that this is a favorable move to not routinely recommend it at birth. And I would just encourage the ACIP to do a very diligent risk-benefit analysis, acknowledging the known risks and the unknown risks, what we don't know, as we have been discussing, and consider why, when we have a similar prevalence of hepatitis B in the United States as they do in Denmark, why Denmark has decided that they should not routinely recommend it to children, and that they should identify children who may be higher risk, and then it can be individual decision making for those children.